Well, I wanted to welcome everybody to this review. I'm going to go over the very images that are going to be on the exam. And so the main reason I'm doing this is to take one last chance to help reinforce some of the things I think are important. And this first one, I think, is one of the most important images you'll ever see. And we call him the hemiplegic man. And when you look at this, I hope right off the bat you realize that he has an upper motor neuron lesion. And his left arm is flexed and his left leg is a little bit extended, kind of shuffling. And I made a note up there. It says the lower half of his left side of his face is weak. So what you got here is you got a lower half of his left side of the face and a left hemiplegia. So you have some obvious cortical spinal damage somewhere, and you obviously have some weakness in the left side of the face. Now, when I look at this, I think, well, he can't be in the spinal cord on the left because it's got to be somewhere where I've high enough to affect his face also. So when I look at this, it could be probably anywhere on the right side, so it interrupts the left cortical spinal fibers. It could be anywhere on the right side above motor 7. So if I've got the cortical spinals and the cortical bulbars in the midbrain or in the rostral pons or in the or even up in his right cortex, I can involve the lower left face and the arm and the leg. If I was down in the LCST, say at C1, I wouldn't have the face problem. So it's got to be high enough up to interrupt the cortical spinals and the cortical bulbars to the lower part that are going to involve weakness in the lower part of the left side of the face. So I'd say a good place would be in the right cortex could do this, in the right internal capsule, which you don't know, the right cerebral peduncle. If you had a lesion in your right cerebral peduncle, you would involve all of your cortical spinals, which are going to decussate, and you involve all of the cortical bulbars. Now, just remember, you only have to worry about cortical bulbars that are going to motor 7, that give you a facial deficit, and that are going to the hypoglossal nucleus, which give you a tongue deficit. Anytime you have an upper motor neuron damage to the cortical spinal or lateral cortical spinal tract, you're going to have all the goodies that go along with in this case, a left Babinski, left clonus. His patellar reflex in the left leg would be increased. His biceps reflex in the left arm. He'd have a Hoffman if you could demonstrate one. He would also lose his abdominal reflex on the left. And he would certainly have a spasticity on his left arm and his left leg. Make sure you know what a Hoffman sign is. Oh, now, I'm also looking there at the position of the uvula. Well, I've just mentioned that if you get those cortical bulbars up there in the right cortex or the right cerebral peduncle, the bilateral cortical bulbar input to nucleus ambiguous for the uvula and to motor 5 for the jaw, we're not going to have any upper motor neuron deficits. Make sure before you leave this slide that you can list all lower motor neuron deficits associated with motor 5, motor 7, ambiguous, hypoglossal, spinal accessory, and then differentiate those from the cortical bulbar problems that you're going to see with cranial nerve 7 and cranial nerve 12. So I think this is a really good slide. You'll see this. I think if you understand what I'm trying to get across, you certainly wouldn't miss the question. I hope everybody gets this one right. The second question is called Stumbling John. I don't know if you know John's in the 3rd year, one of the nicest guys you'll ever meet. What I'm showing here is a person stumbling to the right. So I'm thinking, he's stumbling to the left. I can't even get that right. So he is stumbling to the left, so the right side is kind of dominating. So I would say that there could be a lesion in the vestibular nerve or in the vestibular nuclei on the left, which leaves the right nerve and right nuclei kind of in charge. If the right nerve is firing, right nucleus is firing, you're going down the spinal cord over those vestibulospinal tracts on the right side. So you're going to be more active in the right side in your arm and leg, and you're going to push over to the left side. If you're more active on the right side in the vestibular nuclei, you're going to go over to the left PPRF from the vestibular nuclei. Once you're in the left PPRF, you know your eyes are going to go to the left because the left PPR is going to turn on the left abducens, which move your eyes to the left. So your eyes would go slowly to the left, and then there's a reflex after your eyes go so far left that they can't go any further, snap back to the right. So in this case, where the right side is really dominating, you'll stumble to the left. Your eyes will go slowly to the left, but the nystagmus will be to the right. So it'll be left stumbling, right nystagmus. What else here? I think that should, now, I give a bunch of upper motor neuron signs here. You wouldn't have any of those in this particular case. Number 10 isn't too bad. If John had been spinning in a chair, so let's say you start spinning him. Let's say he's past pointing here to the left. So I'll bet you that in the beginning, I spun John to the left. After a while, the endolymph caught up with a perilymph. And then I stopped, and that would put the right side in dominance. The endolymph would just keep going. So in the beginning, when I turned him to the left side would be dominating. The endolymph would catch up, neither side would be dominating. When you stop, the right side would be dominating. So then he would stumble to the left and have a right nystagmus. So I hope nobody misses this one. You shouldn't. This is classic. You should know it. I hope everybody gets it right. So far you've gotten 2 out of 2. Oh, now we have the man with the droopy right eyelid. You look at this, and you could possibly, with the image on the left as you look at it, some of you could probably say, oh my goodness, I bet he's got a Horner's. On the right side, Big John, he just goes on and on about those Horner's or the ptosis and everything. But this is a little more than a ptosis. This is what you call a really droopy right eyelid. It's down all the way. And this clue tells you that one of the eye muscles in the right eye, called the levator, palpebrae superioris, is damaged. It can no longer elevate your right eyelid, so it's down. So levator palpebrae superioris is innervated by the somatomotor part of cranial nerve 3. So now I'd start thinking maybe you got a cranial nerve 3 on the right. Then I would have him or you lift up his lid like that. You can see that the globe is kind of dominated by the right superior oblique and the right lateral rectus because they're not innervated by cranial nerve 3. So it'd be kind of down and out. And then if you could really get a good look at that pupil, it would be what we call blown. It would be huge because, as you know, the parasympathetic part of cranial nerve 3 is going to constrict your pupil, and the sympathetics that are still remaining are going to dilate it. Now, in the beginning, if the person had his lid down, he would not have any double vision. If you raised their lid or he raised his lid like this, of course, he would have some double vision. What else could I think that's about it. Oh, I know. Where in the heck is cranial nerve 3 coming out of? Is it the medulla? Is it the pons? Or is it the midbrain? And clearly coming out of the midbrain. The other cranial nerve to come out of the midbrain is cranial nerve 4. So you're going to have a lesion here in the midbrain on the right. Another question I could ask you is, where is cranial nerve 3 going to enter the orbit? And like good cranial nerves 3, 4, and 6 are going to go through the superior orbital fissure. So here's the man with a droopy right eyelid. you'd have some lower motor neuron damage, so lots of your muscles would atrophy. Don't forget that. And it comes out of the midbrain. Okay, so now we're 3 for 3. I don't think anybody should have missed any of these so far. They're all straightforward. They're all straight clinical. And they're what you should know to be a good physician. Oh, now we got the lady with the missing left sternocleidomastoid. Well, this should cause your memory systems to be jolted about a cranial nerve that innervates the spinal accessory, or innervates the sternocleidomastoid and the trapezius. Sternocleidomastoid and trapezius. And we're talking about the accessory or spinal accessory nerve. Now, what's difficult about the spinal accessory, or better known as cranial nerve 11, is that its cell bodies are in the spinal cord. The cell bodies are in the spinal cord. The cell bodies are in the spinal cord. Those cells have axons which exit about the middle of the spinal cord. That is dorsal ventrally. They don't go out the ventral root. And they then go rostrally from the cervical cord to go up through the big opening called foramen magnum. Once they're in the foramen magnum, then they can go out the good old jugular foramen and go out to the ipsilateral sternocleidomastoid and trapezius. Now, what else goes through the good old jugular foramen? 9, 10, and 11 all go through the jugular foramen. Now, you don't see a sternocleidomastoid on her left side. There is no sternocleidomastoid there on the left. You can certainly see a beautiful sternocleidomastoid there on the right. So what happened to the one on the left? It atrophied. It atrophied. Now, I know you're all sitting there, getting ready for this exam, and you're going to say, Big John, what the heck? She's moving her head to the right. Well, you can move your head to the right because there's some other neck muscles that we probably never dissect in this course. But look, you can't see a left sternocleidomastoid. Got to be atrophy. Got to be the 11th cranial nerve. Goes to the jugular foramen, also goes up through the foramen magnum. Cranial nerve 11. That's the only component you got there. You'll see this lady, but I'm not going to ask you a really easy question on it. I might ask you like, let's see, who's a maker? What company makes her glasses? That's one question you might look up. What other question could I ask you? Well, I think that's enough. So see if you can find that out, and I'll probably put that on the exam. It'll be the last choice. So it'll be 1, 2, 3, be the 5th choice. So you'll know that's true, because I always choose the last choice, so what the heck. So I'm actually keeping track. This is the 4th one that everybody should have 4 for 4. Oh, the 5th one. Now, when you look at this lady, what's the first thing that comes into your head? That she has some problems with her muscles of facial expression. Oh, now you're going to say, well, geez, is it on the left or right? Well, when I look here, I can see the lady. I can see she's got a nice nasolabial fold here. Nothing here. This is kind of flattened out. And then I look up here, and I can see some furrows over here on this side, which are good because she can wrinkle her forehead over here. But this is flat. This is pretty flat. And her palpebral fissure here, you can see a little more of her eye over here than you can see here. So I would say this lady has a right Bell's palsy. Well, that's, so it's a right Bell's palsy. What cranial nerve is involved? Well, it could be cranial nerve 7 in the periphery, or it could be the motor 7 nucleus in the pons. And again, if you get motor 7 in the pons or the motor fibers out here before they get to the muscle, you're going to have what we call a peripheral 7. That is, the whole half the face is weak or atrophying in Bell's palsy. Now, how do you know this isn't a cortical bulbar damage? Say over here in the left cortex. Well, if she had left cortical bulbar damage, sure, it might look a little bit like this on the contra side, but she would be able to wrinkle her forehead up here on this side and this side, and of course this would be fine. Where could the lesion be down here? Well, if you're going to get the nucleus, it's got to be in the pons. Okay? A lesion of motor 7 in the pons. What else could I ask you? Let's see here. What muscle is weak so that her eyelid does not close? That'd be orbicularis oculi. All right. This is classic Bell's palsy. This is lower motor neuron. Whole half face is gone. Motor 7, a lot of cranial nerve 7 in and out at the pons, at the caudal pons. What you should know to be a good physician. This could be probably the top thing of the first 5 slides, that I want you to make sure you get this. Although it's closely competing with the hemiplegic man. So know those two. All right. I got some good news, because this very patient, they took some nerves from this side and crossed over here to innervate this side. So I have pictures of this lady after surgery. She has a very nice, beautiful smile. So they really did a lot of good surgery on her, and she's a very happy person. Bell's palsy. Oh, now this is the tilting lady. The tilting lady. Now, let's look here. What do we got here? Now, when you say tilt her head, she's tilting her head to ameliorate double vision. Now, this is the key. Tilt. T-I-L-T. Not rotate. R-O-T-A-T-E. Tilt. Tilt. You start thinking about what cranial nerve? You start thinking about cranial nerve 4. If I'm talking about rotating somebody's head to ameliorate double vision, then you're thinking about the lateral rectus abducens cranial nerve 6. So let's take a look here. Right here, you can see pretty well that her eyes are pretty much aligned. She's tilted her head to the left. Now, if she's tilting her head to the left, you're going to say she could have a right cranial nerve 4 lesion or a left nucleus 4 lesion. Do you get what I mean? So this left nucleus in the midbrain is going to send its axons to the right superior oblique. So if you're tilting your head to the left, you could have damage over here in the right nerve or on this side in the right nucleus. Keep that in mind. Look at this. This is kind of like she's got some double vision here. She's trying to look forward. You can kind of tell that she's having some trouble. These are not aligned, okay? So you can this right eye where the problem is probably a little bit, would it be intorted or extorted? If you lost the superior oblique, it'd be extorted. All right? So think about what you'd have to do to get this eye to intort. So if you rotated this way, or if you tilted your head this way, this would intort. It's extorted because of the inferior oblique is working. This, she went the wrong way, and it's really bad. So she's got a lesion over here, probably in the right nerve, right 4th nerve, or left 4th nucleus. Tilting left, problems in the right nerve, left nucleus. What else is in here? Oh, what else should you know about cranial nerve 4? It exits the skull in the superior orbital fissure. That's one thing. It crosses. That's another thing. And it's the only cranial nerve to exit the dorsal surface of the brainstem. And it exits in the midbrain, part of the midbrain. Oh, now, here's the man with a deviating jaw. This should be easy for you. You must know that motor 7 innervates muscles of facial expression. Motor 5 innervates muscles of mastication. Ambiguous gets all that stuff, soft palate, larynx, pharynx, all that kind of stuff. But here, this fellow, when he opens his jaw, When he opens his jaw, it goes to the right. This cannot be cortical bulbar. Why is that? Because motor 5 gets a bilateral input from cortical bulbars. It cannot be cortical bulbar. It's got to be nerve. So it could be the mandibular branch of cranial nerve 5, or it could be on this side, or it could be in motor 5 itself in the pons. But any way you go, you weaken the muscles of mastication on this side, like the tongue, it'll go ipsilateral. Let's go through something else here. No, not cortical bulbars, muscles of mastication. Here's one. Let's go over this one. You might have some problems here. If this man has a lesion of all fibers of cranial nerve 5, well, you know, this fellow has deficits in the motor fibers of cranial nerve 5. But let's say he wiped out all cranial nerve 5. What parts of the corneal reflex occur when you touch his left cornea? Okay, corneal reflex. You come in here, you touch the left cornea. Does it get in? Sure, it goes in with cranial nerve 5, and then it hooks into both motor 7s. So if you touch this left cornea, you get both a direct and an indirect corneal reflex. If you touch this cornea, you wouldn't get either. Could the neurological problems result from a lesion of the midbrain? No, because cortical bulbars don't count. A lesion of the medulla? No way, there's nothing down there. There's nothing down there that has anything to do with motor to muscles of mastication. Spinal cord? I'm just trying to trick you down here. Don't fall for all that. So this is the man with a deviating jaw. Don't ever forget. Lower motor neuron, atrophy, motor 5, cranial nerve 5, mandibular branch. So now where would the mandibular branch go exit the skull? Well, it would be in foraminal valley. Where would the maxillary branch, sensory branch of cranial nerve 5 exit the skull? Foramen rotundum. Where would the ophthalmic branch of cranial nerve 5 exit the skull? Superior orbital fissure. So now we're done with a man with a deviating jaw, and everybody so far has 100. Ooh. What would any good neuro exam be without a deviating uvula and a beautiful tongue to ask you a few little tricky things about the tongue? You got to admit, everybody, no matter where you are, I mean, you could be sitting in a bar and watching this, and you're going to know that that's a deviating uvula to the left. And this is the tongue, and here's some taste buds, you know. Here's the hard palate, and this is part of the soft palate back here. Okay? Now, when I look at a deviating uvula like this, I'm immediately going to think about what cranial nerve damage has occurred. Because I know nucleus ambiguus via cranial nerve 10 is going to innervate this. I also know nucleus ambiguus is good. So it gets a bilateral input. So no lesion involving cortical bulbars are going to give you any deficit here. It's got to be a lower motor neuron, and it's going to the left, so I know it's going to be a lesion on the right because it goes to the strong side. So it could be in the right cranial nerve 10, or it could be in the right nucleus ambiguus. And remember, cranial nerve 10 goes out the jugular foramen. So you could have a lesion in the right jugular foramen. Now, then we take advantage of the tongue. So back here, I'd call this the posterior third, out here the anterior third. Then I'd start asking you some questions about the posterior third, because that's easy for me to remember because it's innervated by only one cranial nerve 9, for pain and temperature and for taste. So I'm thinking taste from the posterior third of the tongue would be cranial nerve 9. Pain and temperature would be cranial nerve. Which ganglia, though? Well, taste is going to be the inferior. Pain and temperature is going to be the superior. Then I come out here to this anterior 2/3 of the tongue. I don't like it quite as well because I got to remember two cranial nerves. One, if I burn the tip of my tongue, which is going to be certainly trigeminal. Trigeminal out here, anterior 2/3 of the tongue would be trigeminal. But taste from the anterior 2/3 of the tongue is going to be cranial nerve 7. Well, you don't have to worry about either one of these because you only got one ganglia with each. Out here for pain and temperature with 5, trigeminal ganglion. Out here for taste from 7, the good old geniculate ganglion. Good old geniculate ganglion. I think you'll get everything right here if you followed whatever I said. And let's go on to the next one. Oh, this guy is a very famous man. We call this fellow Mr. Paranoid, or Parinaud. Sorry, I shouldn't make a joke like that. Parinaud syndrome. Parinaud syndrome. Now, this fellow is trying to look up. He cannot get his eyes to go up. He cannot get his eyes to go up, so he's got to move his whole head to look up. Parinaud syndrome is something you're going to see next year in your clinical course. Results from a bilateral lesion of the superior colliculi. Well, where in the heck are the superior colliculi? We're not even in the midbrain in this course yet. Well, superior colliculi are in the midbrain, and they're visual structures among other things. But what lies right above the superior colliculi would be the pineal body. And sometimes the pineal body gets a tumor that presses down on the colliculi, and the result is Parinaud syndrome. So where are the superior colliculi? They're in the midbrain. So if we go to the second question, could this patient have a lesion in the midbrain? Yes. Pons? No. Medulla? No. Okay. What else we got here? Superior colliculi? Yes. Looking through here to see what you're... Oh! Now I know there's some of you, if you're watching this late Monday night, you're saying, I never heard that guy talk at all about the ventricular system. Oh, once in a while it was on a slide, but the ventricular system he really didn't talk about. Well, I'll talk about it briefly here. When you're in the midbrain, you have a part of the ventricular system, that is, the ventricular system just is containing fluid, the cerebrospinal fluid. And when you're in the midbrain, the part is called the aqueduct, cerebral aqueduct. When you're in the fourth ventricle, then it's called, or when you're in the medulla and pons, it's called the fourth ventricle. So this, in the case of the midbrain, it would be the cerebral aqueduct. Now look at this. The man's bilaterally wrinkled forehead suggests that he also has a bilateral lesion. And that is really, really, I hope nobody misses that one. Now, how about this one? The pain and temperature fibers from the man's ears could have their cell bodies in which 4 cranial nerve ganglia? Well, trigeminal, geniculate, superior, 9, superior, 10, and those axons are going to go in the spinal tract 5. Lots of confusion of people that I've been working with. Spinal tract 5, pain and temperature. Solitary nucleus. Poor little solitary nucleus. Taste. Salivatory nuclei. Salivation. All right. So we'll let the Parinaud man go. I don't want anybody to miss that. Next slide is, I hope it's interesting. It is interesting. What is more interesting than the tongue? This one right here. This picture here. Wow. If you've never seen a tongue with atrophy, this is a tongue with atrophy. Over here, I have a little arrow meaning no, there's no atrophy on any side of the tongue. I mean, this is, no atrophy. So in this particular case, if there's no atrophy and the tongue is going to the right, he has to have a lesion probably up here in his left motor cortex that get those left cortical bulbars. Now, you could get those cortical bulbars going to his right hypoglossal, way up here in cortex, way down in the midbrain, way down in the pons, anywhere in the medulla rostral to the hypoglossal nucleus on the left. Over here, bilateral, where could you get that? Well, you're going to have to maybe you could have bilateral tumors in some foramen. The foramen in which the cranial nerve 12, hypoglossal, exits the skull. And that would be the hypoglossal foramen. Or some people call it the hypoglossal canal. Sorry about that. I got up. I'm going up to turn off the darn lights. And I had the microphone, and you know me, so hang on. Got to turn the lights low. All right. Everybody okay? Didn't mean to wake you up, but now I'm going back to my seat. There's nobody in this room. It's so lonely. I mean, nobody to call on. All right. Where are we? So the bilaterally atrophied tongue, like I said, you could have bilateral lesions in the hypoglossal nucleus. You could have lesions in the hypoglossal canal, something like that. But it's got this one's got to be lower motor neuron. This one again is upper motor neuron because there's no atrophy. What else could I ask you? Oh, if the man has a lesion, oops, how'd that A get in there? If the man has a lesion A in his left motor cortex, then his uvula would most likely deviate to the right upon saying, ah. Huh? No. Remember that? Bilateral. Don't ever worry about that darn uvula. How about this one? If the bilaterally atrophied tongue resulted from a bilateral lesion of cranial nerve 12, then the patient's taste and pain and temperature from the tongue would have been lost. Come on, you know that. All right, cranial nerve 12 is just, not that interesting. It only goes out and moves muscle. I mean, what do you say about a cranial nerve that only moves muscle? Hopefully you want a cranial nerve that's carrying sensation and moving muscles and all those kind of things. So cranial nerve 12 is pretty darn easy. Most of you are going to get this, I hope. All right. So far, you're batting 100% if you're still with me. Whoop, went the wrong way. Oh, now into the eye movements. The dominating medial rectus. Well, always start here. This is a person looking straight ahead. And this eye and this eye. Now, this eye is having a little trouble here because it's trying to look straight, and it's deviated medially. Why? Because this patient probably has a lesion of the left lateral rectus. How can we check that out? We look to the left. Right eye goes, left eye gets right there. So it looks like it's a lower motor neuron lesion, could be in the abducens nucleus, could be in the rootlets. On the left side as they come down by the PPRF, or they could be, you could interrupt cranial nerve 6 in the superior orbital fissure too. Okay, so the questions are, the patient could have a lesion in the left cranial nerve, left CN6. Is that true? Yep. The patient could have a lesion in the left abducens nucleus. Well, what if it's in the nucleus? Would you affect one eye like this or both eyes? So you would affect both eyes. How about the patient could have a lesion in the right frontal eye fields? Well, if you had a lesion in the right frontal eye fields, you couldn't move both eyes to the left. The patient could have a lesion in the left medulla. How would you ever get cranial nerve 6 in the medulla? A lesion in the left MLF, now, this affects both, left MLF. Well, if you have a lesion in the left MLF, what can't you do with its eye? You can't turn it medially. And of course, doesn't matter whether you voluntarily or use the vestibular reflex to get this thing to go left, it won't go left. How about the cell bodies lie in the midbrain? Well, there are some cells in the midbrain that innervate eye muscles. That would be from cranial nerve 3 and cranial nerve 4. Cranial nerve 6 comes out of the pons. That you got to know. Oh, finally a Horner's. Well, this is a droopy eyelid. Notice It's not like in a cranial nerve 3 where it was already down, way down. So here is a droopy eyelid, and then look at this pupil right here versus this one. So in the Horners, where you get this, you're interrupting sympathetics, you're going to let that old parasympathetic and cranial nerve 3 take over, so it'd be constricted. Now, you could get this Horners. Of course, you have other things, you know, lack of sweating and things like that from the face. But depending upon where you interrupt things, you can get some other things. So let's say we interrupted the descending hypothalamics in the midbrain. Traveling with the ALS, you would get the Horners, no sweating from the face or body. Let's say you got it in the pons. You'd have an Ipsy Horner, same thing. Say you got it in the medulla, same thing. So just think when you're in the brainstem and you have a lesion that involves the anterolateral system, you're going to have a pain and temperature deficit on the contra side and the Horners on the Ipsy. But you can interrupt those descending hypothalamics anywhere in the brainstem, anywhere in the brainstem. Look at this last one. This patient has diplopia. Well, are both eyes kind of aligned? Of course they are. This one. Oh, I love this one. I love this one because it shows some of my favorite somatomotor cell groups. Look at this. Somatomotor. Somatomotor. Well, the first somatomotor we ever learned was the hypoglossal. Hypoglossal, axons down and out to the tongue. On the midline. Notice it's on the midline. Next one was abducens. Somatomotor. Axons run down, go out to the lateral rectus. The next one was cranial nerve 4, trochlear, on the midline, sitting right in that good old MLF. Cell, axon, comes down around, going out to get the good old SO4, superior oblique. There's a little piece at this level too, that's all that means. And finally, the good old ocular motor, it's got somatomotor, going to lots of muscles, and it's got also some visceral motor here. The good old, I know you all remember this name, Edinger-Westphal. So this is cranial nerve 3, 4, 6, and 12. Well, since these cranial nerves are next to the midline like this, you can see it's very easy, and you can see that you can get the nerves along with one of the most famous pathways in the world. Now, this is called the cerebral peduncle. This is the smart peduncle. This is the superior cerebellar. This is the middle cerebellar, the inferior cerebellar peduncles. This is the cerebral, because things in this are coming from the cerebral cortex, up top, very important. You know, these other ones are just related to pathways going to and from the cerebellum. So now let's combine some things here. Let's say we had lesion 1 here. You're going to get every cortical spinal fiber in here. You're going to get every cortical bulbar fiber in here. They're all in here coming down to get off into their wherever they want. And remember, the cortical spinals will cross, all right? And the cortical bulbars are kind of weird. So let's take this one right here. You would have a problem with this pinkish one here, the muscles of the globe, except for superior oblique and lateral rectus. Here you'd have fibers, preganglionic parasympathetics, going out to a famous ganglion in the orbit called the ciliary ganglion. So if you interrupted these fibers right here, these autonomics, you would have a dilated pupil. Now, at the same time, in the same lesion, you could get some substantia nigra here, which is going to give you some Parkinson deficits, but you're going to get corticospinals, cortical bulbars, and corticopontines. Now, let's do it. This would be in the right cerebral peduncle. So you're going to have a left hemiplegia. Your tongue is going to go left. Your uvula is going to be straight. The left side of your face below the eye will be weak, and when you open your jaw, it'll be straight. So all those cortical bulbars are in here, all these cortical spinals, in addition to the eye movement problems. Now let's go down to 4. Now here, you're going to have a problem here with the ipsilateral superior oblique. Ipsilateral to this lesion, superior oblique. So you're going to tilt your head to the opposite side. Tilt your head to the opposite side. Now, when you have a lesion in these cortical spinals, you have contralateral hemiplegia. When you get those poor cortical bulbars, you're going to have a contralateral tongue, a contralateral face that's weak below the eyes, and a jaw that's on the midline, and a uvula that's on the midline. You come here, you get some more interesting things. Oh my goodness, let's take a look here. Well, here's a cell body coming down to the lateral, going out to the lateral rectus. So this eye will be deviated which way? Medially. And you're going to get the cortical spinals and the cortical bulbars that are at this level. And so here you'd have a contralateral hemiplegia, a contralateral tongue, your uvula would be straight, and your jaw would be straight. Now, whether or not these axons have gotten out to go up to motor 7, it depends. But I would think, I've got a drawing that says, that shows some that are going up into here to motor 7. But one rule I want you to keep in mind is that if you can see the nucleus, can you see motor 7? Yes, in this slide. So I have a lesion here. Can you see motor 7? If you can see motor 7, that means the cortical bulbars to motor 7 have gone from being in here to being in motor 7. In other words, they're not in here. If you see the nucleus, they're out. If you see the nucleus, they're free. If you see the nucleus in the same level, that means that it's still innervated with this cortical bulbars. In other words, the cortical bulbars for 7 right here would not be in here, regardless of what one of those little diagrams show. So if I was a cortical bulbar going to 7, I'd be here, I'd be here, I'd be here, I'd be here, I'd be here. Now I'd start thinking about getting the heck out of here and going into motor 7. Filter up here into motor 7. So that when I have a lesion down here and I look up here at motor 7, the cortical bulbar-wise, it's normal because they've gotten out already. Okay? So cortical bulbar-wise here, you'd have them mainly, the only thing left down here is going to hypoglossal or to the cervical cord for, trapezius and sternocleidomastoid. So the hypoglossal cortical bulbar would be in here, and then it starts to sneak over here before it gets here. In other words, it's going to exit around here and go over here. So let's do the cortical bulbar. Let's do that. Contra tongue, contra tongue, contra tongue, contra tongue, contra tongue, contra tongue, contra tongue. Now, if you had a lesion here, as far as cortical bulbars, they're already out. Okay, and the only thing left here would be those going to the cervical cord. So but since we got a lesion of the hypoglossal nerve here, let's do that. This would give you an ipsilateral going tongue. This would give you a contralateral hemiplegia. And remember the cortical bulbars to the cells in the cervical cord for spinal accessory or bilateral. Now, since I've confused you all on this and you're all avidly looking through your course book, let's go through it again. The only cortical bulbars you got to worry about go to motor 7 and hypoglossal. Now, a lesion here would interrupt them because motor 7 and hypoglossal are far caudal to this. So if I had a lesion here, I'd have a contra tongue and contra face below the eye. Same thing here. Same thing here. Same thing here. Same thing here. Ooh. Now, I'd say your face is okay, but your tongue is still going to deviate. Here, your face is okay, but your tongue's going to deviate. But then they're getting off in here. So I'd say if you had a lesion here, you'd have a hemiplegia, but your tongue would be okay. Now, I know that's confusing, but I think you can do it. All right, let's go on to the next one. Ooh, one of the most important cranial nerves ever. Cranial nerve 5. Let's go over it. How do you know it's cranial nerve 5? Oh, I got a little star right here. Geez, what is that? Here's the Fab 4. I know that. This little thing must be the STT. This little thing must be the good old MLF. This is something called the lateral lemniscus. I certainly haven't worked much with those auditory pathways, have I? Let's take ganglia. Here's a ganglion. It comes in, and it descends. What do you think this is? These are going to descend in what? Spinal tract 5, pain and temperature. Here's a ganglion. It comes right into the good old, here goes, where are you? Goes right into the good old chief. So this ganglion, this cell, because they're both in the trigeminal ganglion, this cell is carrying two-pointed cetera. This cell is carrying pain and temperature. So if you're a two-pointer, you come in, synapse on a cell up to TTT. If you're a pain and temperature, you poor person, you poor guy or gal, got to descend in the tract all the way down along the nucleus to the caudal nucleus where your synapse and go up to TTT. So it's rostral to here. The TTT is going to have both pain and temperature and 2-point in it as we go rostral. Oh, then we got this one right here. We got this lower motor neuron, branchial motor neuron here that's going out to the wonderful muscles of mastication. If you lost this neuron or this nerve, your jaw would deviate to the ipsilateral side. We also got this guy right here. Oh my goodness sakes. There it goes. Here is a cell. Here is a process. Here is its other process. It's like taking a cranial nerve ganglion like this, one cell, two processes, taking it from the periphery and putting it in the brain. And we call it the mesencephalic nucleus of 5. This little cell here has two processes. One goes down to motor 5. The other process goes out. And this is coming in from muscle spindles and Golgi tendon organs. Isn't that weird? So this would be a little unconscious proprio coming in from the muscles of mastication. But the cell body is not in a ganglia out here. It's actually in the pons. And this little cell group runs up into the midbrain. That's how it's got its name, mesencephalic nucleus of 5. So you can see like any kind of stretch or any kind of information there would go right down into the motor nucleus for a jaw reflex. And then also there are some little projections from this cell that go into the middle cerebellar peduncle to go up to the cerebellum. Usually don't emphasize that too much, but I always get a lot of questions because I found if you don't emphasize something or leave it out, then everybody thinks that you're going to trick them, ask them something on the exam. All right, what else? Oh, here's the middle cerebellar peduncle, right? So these fibers just go through it to get up here. Cranial nerve 5, you're definitely going to see something about it. Wherever the cell bodies of the STT be, they be in the ipsilateral nucleus solitarius about level 3. These are these ones that are going up to VPM or are carrying taste. Cranial nerve 7, the scone on the tip of my tongue. Oh my gosh. Well, you know I like those scones, but I also like oatmeal at my favorite coffee shop. But this is not a joke to Nicole, who, remember, we were talking about something in that solitarius, and she said something about that she likes baroreceptors or something like that. So don't take it the wrong way. It's just that I have fond memories of talking about nucleus contractus solitarius. Cranial nerve 7. Let's go over the components. Plus, we've got a big lesion here. Well, here's first thing we ever learned were some pain and temperature fibers come in here. Spinal tract 5. geniculate ganglion. Then we also learned other cells in the geniculate ganglion come in and, going to descend. Where do you think they're going to descend to? They're going to descend in a little bit caudal to go down to the solitary nucleus, synapse, and then up the STT to VPM. So this would be taste. And the only reason I've shown an arrow there is there's not a lot of solitarius up here. It has to go caudally. Then we got the most important part of cranial nerve 7, motor 7. Its axon loops up and over the abducens, forming the facial colliculus, up and over, and goes out to the muscles of facial expression. And then we got the other one here, a preganglionic parasympathetic cell group right here, called the superior salivatory lacrimal. This is the third one we've had. We've had the dorsal motor 10 by the time we get up here. We've had the inferior salivatory 9. Now we have the superior salivatory lacrimal right here, medial to motor 7, that goes out with cranial nerve 7. Going to go to 2 ganglia, pterygopalatine, synapse onto the tears, and then submandibular synapse, submandibular ganglion, and then go out to the submandibular gland and sublingual gland. So you can think about this. Wow, what kind of, geez, look at this. A lesion like this, well, you'd lose a little pain and temperature from the ear, here. You'd lose taste from the anterior 2/3 of the tongue. What's this one? This one is hard to tell. This one's muscles, facial expression. And this one's preganglionic parasympathetic. So you can think of all the little good things that would happen with a lesion of cranial nerve 7. Let's see here. Oh, unilateral damage. Let me do this one. Where are you, pointer? Unilateral damage to cortical bulbar fibers at this level. Can you see motor 7? Boom. Cortical bulbars are in here. Cortical spinals are in here. Can you see motor 7? Yes. Cortical bulbar, cortical pontine, cortical spinal. Can you see motor 7? Yeah. That means there are no cortical bulbars down here going to there. All right. So let's answer this. Unilateral damage cortical at this level will result in contralateral deviation of the tongue. Well, yeah, because we're rostral to hypoglossal. I didn't even ask about the face. Geez. But has no effect on the uvula. Darn right. Cortical bulbars never affect the uvula. Never. How about this one? This level of brainstem contains a PPRF. Well, there it is. What's your clue? Abducens nucleus, MLF, rootlets is 6. It's all kind of one system. We're lucky it's all right here. Here's a good old Fab 4 right here. Okay. All right, you know this level. Don't miss this level. Jeez. Okay. Now, I like this level, too. This is one of my favorites. And I also threw in an MRI up here. This is me up here. Let's see. My left side of my face now has a little bit of droop to it. Okay, well, let's go over here. Level 4 in all its glory. What cranial nerve are you thinking about? I know the one I'm thinking about. Cranial nerve 8, auditory, dorsal cochlear, ventral cochlear, inferior cerebellar peduncle, but then the other part of the 8th nerve, the vestibular nuclei. Just call them vestibular nuclei. So when I look at this level, you know, I got cortical spinals, I got ALSs, I got beautiful medial lemniscus, I got TTTs, STTs, ALSs, and descending hypothalamics. But for me, it's cranial nerve 8, ventral cochlear, dorsal cochlear, vestibular. Now, the cell bodies for the auditory part would be in the cochlear ganglion. The cell bodies for the vestibular part would be the vestibular ganglion. And you know, vestibular ganglion, the peripheral processes go out to semicircular canals, utricle and saccule. You know, for the cochlear ganglion, they go out to the hair cells that help us hear. So if I had a big whopper right here, which is right there, see the pyramid there? That's beautiful. See that little bump right there? That's the olive. It's a little different. We don't see much olive here, but, you know, Here's all cerebellum. Here's a lesion. My incoordination would be ipsy. My deafness would be ipsy. Now, big lesion here, well, the other one's going to dominate. It's going to push me this way. So if this is the right side, and I have a lesion here, it's going to push me to the right side. This one's going to work, and it's going to go over to the PPRF on the right side and push my eyes slowly to the right, snap back left. So you're going to stumble to the right and have an nystagmus to the left. I could ask you where these terminate. You could say down the spinal cord, vestibulospinal tracts, or you could tell me they go to the opposite PPRF. I think that at this level of the brainstem, the medial omniscus have not joined each other in Fab 4. That's true. This occurs at the level, darn right. Oh, you know this. Unilateral damage to cortical bulbars. Let's think about what would happen here. Are we caudal to motor 7? Yes, we are. Are we rostral to the hypoglossal nucleus? Yes, we are. So cortical bulbars at this level, the cortical bulbars to the opposite hypoglossal are in here. The cortical spinals are in here. So you have a contralateral hemiplegia and a contragoing tongue. Would it be fair for me to show only an MR with a red star? Well, probably yes. Except that, the pyramids are good, but you got a good olive there, and this one doesn't show a good olive. So, I don't know, I doubt that. Presbycusis man. Well, does he really have presbycusis, or is he deaf? Maybe I should call this a deaf man. Next one. Oh, now this one is from a case that we probably won't get to because I'm so slow, and but we might. Now, I hope everybody knows that we're looking down on the left side of the skull of the cranial fossa here. The brainstem would be here, and these are the nerves that are leaving the brainstem. So we know some of these. Here's the trigeminal ganglion right here. And we know ophthalmic going up to the superior orbital fissure. We know maxillary going through foramen rotundum. And we know foramen ovale. All right, so we know that. You could probably answer questions about if I had little problems with these little foramen, a tumor in each one. Now, here's the internal auditory meatus, which we're not quite as familiar with, but we did study quite a bit, cranial nerves 7 and 8. Now, you see where I wrote 7 up on top of Coke? Isn't that cool? That means cranial nerve 7 is on top, and the cochlear vestibular is on the bottom. But for you guys, we just get them both, 7 and 8 right here. Then we go to 9er, 10er, 11er, and hyperglosser. Okay, so you notice I kind of fixed this up from the PowerPoint that I gave you. I don't want to make it clear. Here's just 11, 10, 9, 12. And look, this was originally labeled anterior condylar canal. Well, hypoglossal canal, hypoglossal foramen for us. These 3 are going through the jugular foramen, internal auditory meatus, foramen ovale, rotundum, superior orbital fissure. So the person had a tumor in here. So can you see, if you have a tumor in here, you're pressing on the nerves. You're outside the pons and medulla. You're ventral to the medulla and pons. You're getting a tumor. Say you got a tumor in this canal that kind of comes out and gets these nerves. You're not going to have a lesion in the brainstem. You're having a lesion peripheral to the brainstem. And look at this small space here where you can get all kinds of goodies. Now, I put a box around this cranial nerve 4 because I like cranial nerve 4. Sometimes this tumor can get cranial nerve 4. You can see old cranial nerve 4 is going up there through the superior orbital fissure. You can't see 3 and 6, but it goes up through there. Now, this is I even labeled it for you, This is the left side. This is the left cranial nerve. 4. So which way would you tilt your head to this tumor here? Well, you'd have a weak left superior oblique, so you tilt your head to the right. You'd also have some hearing problems. Do you agree? You might be deaf in the left ear. If you got 7 on the left, you could have all kinds of problems with muscles of facial expression on the left. And if you got the vestibular system on the left, wow, the right side, the right nerve is okay. You'd be stumbling to the left and have a right nystagmus. If you got 9, what would you have? Well, you'd lose that poor little stylopharyngeus muscle. On the ipsy side, you'd lose some pain and temperature and taste from the posterior third of the tongue. Okay? Say you got the good old tenor here. Well, let's think 10. Which way is your uvula going to deviate? Well, it's going to deviate to the other side. Here's 11, spinal accessory. Well, which shoulder is going to droop? The left. Which way would your chin be rotated? Well, the left one's shot. Usually rotate your chin to the right, so it'd be deviate a little left. And here, wow, here's a good old hyperglosser, a nerve. So now, it's to be lower motor. All these are lower motor neuron. Here, if it's a hypoglossal nerve on the left, your tongue will go to the left. There's a lot here. But you've never seen this way. But this is a good way. Because, you know, sometimes people do the case for this, and they got about 25 lesions in the brainstem. You don't need 25 lesions of the brainstem. You have one little tumor right here, and it can be really bad. A little schwannoma here. All right, the Schwann cells around this nerve kind of get bad and kill everything. This is not a very big space. If you had to take care of all these clinical deficits by lesions in the brainstem, you have 25 or 30. So you'll see this on the exam. And make sure that you understand what's in the red box there. I like the red. Oh, and here's a tilt. Listen, here's the left 4, and the fellow's tilting to the right. My goodness, doesn't that make sense? Does that help you? Great. Ooh, one of the most common syndromes in the medulla is called lateral medullary syndrome. Medulla, lateral, medial. Lateral medullary syndrome. In fact, I found one in the literature. The white area here is the lesion. Look at that. Wow. Here's the pyramid. Here's the olive. Medial lemniscus, hypoglossal, dorsomotor. Solitary complex, taste. Solitary complex, taste. Spinal tract 5, pain and temperature. Accessory cuneate, inferior cerebellar peduncle. So here's a little lesion over here on the left side. It gets the inferior cerebellar peduncle. It gets the nucleus ambiguus right here. And it gets some of the spinal tract 5 in here. And, I forgot about ALS and descending Is this dead? I mean, all the goodies in here. You're going to get deviation of your uvula. Which way? Strong side. You're going to get loss of ALS, pain and temperature, contra. You're going to have a Horner's on the ipsy. The inferior cerebellar peduncle is going to give you some problems with incoordination on the ipsy side. And you're going to have problems with pain and temperature from the ipsy side of the face. Ipsy side of the face, contra side of the body from the ALS. This is a wonderful, there's a special little artery that gets this called the posterior inferior cerebellar artery. So sometimes this is called the lateral medullary syndrome or Wallenberg syndrome or PICA, P-I-C-A, posterior inferior cerebellar artery syndrome. Wow. Lots of goodies in here. Lots of goodies. So don't forget, this inferior cerebellar peduncle is going up to this cerebellum. So you can have all kinds of ipsilateral cerebellar problems. Gills. Everybody wants to know what branchiomotor is. Branchiomotor or branchiomotor. Well, I put this together for you because I know that you're probably still wondering branchial motor, but here are the gill arches. You know, we have these during development, and there's muscle in here that becomes, this muscle from the gill arches becomes the muscles of mastication, 5 muscles of facial expression for motor 7, and nucleus ambiguus and its muscles is innervate, soft palate, larynx, pharynx, all those kind of things like that. So now, can you find these branchiomeric motor nuclei? These are all lower motor neurons. So let's go back here and find any lower motor neurons here at all, period. Somatomotor or branchiomotor? What do you say? You looking? I don't think there are. Any lower motor neurons here? I don't think so. Any lower motor neurons here? Well, hypoglossal is somatomotor. Nucleus ambiguus is branchiomotor. Goes out, cells in here go out with 9 and 10 to muscle. The main deficit you'd see here would be, well, if you got nucleus ambiguous, you have dysphonia, dysphagia, uvula that deviates to the contra side. You'd have an effect on your gag reflex. You could play around with that. Let's say I had a lesion here on the left nucleus ambiguous, and I stimulated this side of the pharynx. Would you have a direct gag reflex? No, it's dead. Would you have an indirect? Yeah. What if you stimulated this side with the same lesion? You'd have a direct but not an indirect. So there's 2 lower motor neuron cell groups here, hypoglossal, ambiguous. Any lower motor neurons here? Ooh, I don't think so. This is dominated by cranial nerve 8. Come up here, any lower motor nerve? Yeah, there's a gold one, Motor 7, muscles of facial expression. All right. So if I had a lesion there, I'd have a complete Bell's palsy on the ipsy side. So you've got ambiguous for 9 and 10, motor 7 for 7, and then you go to motor 5. These cells have axons that just go out and get muscles of mastication. Any other, let's see here, let's go up here. What lower motor neurons do you have here? Motor 7 and abducens. What lower motor neurons do you have here? Motor 5. What's going on here? This is dominated by the superior cerebellar peduncle. No lower motor neurons. This is again dominated by the superior cerebellar peduncle. A little piece of the trochlear nucleus here. Again, it's dominated by the superior cerebellar peduncle. A little piece of the trochlear nucleus here. Here, dominated by the ruber-duber-sluber, ocular motor, lower motor neurons. So know where your lower motor neurons are. Know the cranial nerves, because it's going to help you localize. Okay, let's go to the next one. Things get blurry when I look to the left. Well, when you look here, now, we haven't spent much time here, but you know everything here. You know everything here. Here are your cortical spinals, cortical bulbars, cortical pontines. Here's your famous what? What's in here? Your famous Fab 4. Here's dominated. Again, this rostral part of the pons and midbrain, dominated by the superior cerebellar peduncle. There's something called the lateral lemniscus, which I definitely won't ask you. But here's a nucleus right here, cranial nerve 4, sitting in the fibers of the MLF. Oh, I think I'm mainly pointing to the fibers. Let's see. The blue arrows point to the right MLF. Okay, so we're talking fibers here. I'll tell you whether or not I'm pointing to a nucleus or fibers. So we're talking about fibers. But here is cranial nerve 4 here. Remember, it'd go like that. Okay. We're talking about the MLF. So I could ask you, gee, where are we? Well, we're in the rostral pons, almost moving up into the caudal midbrain. Where are the cell bodies for the medial longitude? No, where'd they start? They started down a couple levels in the contralateral abducens nucleus. Remember that? Where are they going to terminate? In the ipsilateral ocular motor. Well, where is the ocular motor nucleus? It's rostral to this, so these fibers are heading up there. But they started in the opposite abducens, and now they're going to terminate in the ipsilateral ocular motor on neurons that innervate the medial rectus. So if I had a lesion here, would I have any lower motor neurons deficits? No, because it's headed for a lower motor neuron. It's not going out to muscle directly. So this is heading to a lower motor neuron up in the midbrain that's going to innervate the medial rectus. So if you had a lesion here on the right side, if you had a lesion here on the right MLF, you'd have difficulty turning your eye this way, ipsi medially, either by the vestibular-ocular reflex or by voluntary control from the frontal eye fields. Okay, so what else is in here? Let's see. What cranial nerve can be seen crossing? Come on, that's cranial nerve 4. Now, oh, look here. The cortical bulbars in here. Let's go in. What cortical bulbars would be here? Well, would cortical bulbars to motor 5 be here? Yes. Do you need to worry about them? No. Would cortical bulbars to motor 7 be in here? Yes. Do you have to worry about them? Yes. If you had a lesion of those here, you'd have a contralateral facial weakness below the eyes. Are cortical bulbars in here to the hypoglossal nucleus? Yes. Will you have to worry about them? Yes. Your tongue will go contra. Are there cortical spinals in here? Yeah. Where's Babinski? Contra. All right. So I think you'll be okay here. What else? Yep, I think you'll see this. Everybody's going to see an MLF lesion. And medial longitudinal fasciculus. Now, some more eye movement. More, I'm really colliculus. Colliculus means bump. The bump is formed by the abducens nucleus. Lower motor neurons come down like this. Interneurons go up the opposite MLF. The other component of the facial colliculus, this little bump, would be the fibers from motor 7 that come up and over. D would be the fab 4. Only one of these would be ipsilateral, one of the deficits, that is the Horners. What else is in here? Medial lemniscus, TTT, STT. Here's a good old PPRF. So I could ask you where the vestibular input's coming from. You say contralateral vestibular nucleus. I could ask you where the voluntary cortical input, you say contralateral frontal eye fields. I could ask you where the cell bodies are for A, and they'd be over here in the millions and millions and millions of pontine gray cells over here. They have axons which cross and go in here to the cerebellum. So a lesion here would give you ipsilateral incoordination. A lesion of the pontine gray cells over here would give you contra. This is something called the superior olive, lateral lemniscus. These are auditory structures. All you'd have to know if I wiped those out would be a subtle auditory deficit. There's a little nucleus medial here to motor 7. It goes out with cranial nerve 7. This would be the superior salivatory lacrimal going out. So a lesion right in here, what the heck? You'd get these fibers, which would give you a Bell's palsy ipsy, and you get this nucleus, which would mean you couldn't move your eyes this way. Couldn't move your eyes this way. Have a lesion in PPRF, you can't move your eyes the same way. Always think about that. Let's pick one thing here. How about C as a big integrator in the sky, the famous PPRF? Yep. It receives input from the contrafrontal eye fields, yes. Contravestibular nuclei. Wow, all these are yes, aren't they? Well, all right. You'll be set on this. I love this level. Now, this MRI down here, look at this. A, what do you think A is? Middle cerebellar peduncle. There's the fourth ventricle. Here's the little bump. Isn't this cool? Here's the middle cerebellum, and this is all cerebellum. All cerebellum. Preganglionic parasympathetic. Is there anything more hated or dreaded or more vilified than the poor preganglionic parasympathetics? I don't think so. Even my lifelong friend, Dave Van Lieshout, when he first was learning his neuroscience, had trouble with the preganglionic parasympathetics. And now, as you'll find out when we get to head and neck, dissections, he could write a book on preganglionic parasympathetics. But you know that there are 4 cell groups that provide preganglionic parasympathetic axons into particular nerves. The first one we ever talked about was that good old dorsal motor down here. If I can find a pointer, the lights came on again. Where's my pointer? Oh, there it is. Dorsal motor 10 has cell bodies whose axons go out with cranial nerve 10 to postganglionic ganglia near the organ. Lesion here, you lose the parasympathetics, heart rate would go up. Cranial nerve 9 has its cell bodies just medial to nucleus ambiguus in the inferior salivatory nucleus. They're going to go out with cranial nerve 9 to the otic, OTIC ganglion. After that, the otic projects to the parotid. Then we go up to the superior salivatory and lacrimal, medial to motor 7. They're going out with cranial nerve 7. Some are going to the submandibular ganglion, which then goes to submandibular gland and sublingual. Some are going to a long word called pterygopalatine ganglion, synapse, onto the lacrimal gland. Finally, we go up here to the good old Edinger-Westphal. Edinger-Westphal, you can call it Ed West, sure. Edinger-Westphal preganglionic para goes out with cranial nerve 3 to the ciliary ganglion, from the ciliary ganglion to the sphincter of the iris. So if you had a lesion of any of this, any of the preganglionic para, you'd have a dilated pupil, a blown pupil. All right, the lights are on. I like to turn them off, but I'll try to keep going. Oh, here we are. I'm going to go down and turn the lights off again. This one is a killer. This one is a killer. But I actually think this is one of the most exciting slides on the exam. Because for a guy like me who likes cranial nerves, and boy, I could teach a whole course right here. I bet I could write, well, maybe 100 practice questions on this one slide. But I think, oh my gosh, I got lots of questions here. I don't know. Which ones are you worried about? Would everybody, well, I guess we should go through them. Should we go through them in order, or should we try to, I couldn't do it in reverse order. So let's, we're looking at the ventral surface. So here's the medulla. Here's the pons. In the midbrain, the base, we can only see right about here, where we see cranial nerve 3 coming out. So A would be the inferior olive. A would be the inferior olive. So what would you say there for your deficit? Ipsi or contra in coordination? Well, I'd say contra. Here's the pyramid. Pyramid right here. And I could ask you, all these cortical spinal fibers in here, would you, and then we're rostral to the decussation in the pyramid. So if I said to you, gee, where's your Babinski, ipsi or contra? You'd have to say contra. C is the pons. C is the pons. And let's just say I dug down in deep here in this side of the pons, and I injected a virus that killed every one of those millions and millions and millions of pontine gray cells. So your in coordination would be ipsi or contra. Well, I'd say contra. D, big, fat, cranial nerve coming out of the midbrain. Now you're thinking, coming out of the midbrain could be 3 or 4. But there's only one that comes off the ventral surface of the midbrain, which is 3. So then you start thinking of a lesion here. My goodness, the lid would be down. The globe would be rotated down and out. Pupil would be blown. Lots of atrophy. Cranial nerve 3. E, this causes, you'll have to do make a major decision here. This is one cranial nerve here. These are the sensory fibers of cranial nerve 5. These are the motor fibers. So what would happen, for instance, if I had a lesion of these fibers here? Which way would your jaw deviate? Ipsi or contra? It would deviate ipsi. What if I had a lesion here, all right? all the sensory fibers. All the sensory fibers. Let's say I touch the pharynx on this side. I touch the pharynx ipsy here. I got a lesion now. Touch the pharynx. Do I have a direct? And do I have an indirect? And you're going to be saying, what? What the heck does the trigeminal nerve have to do with the pharynx? The only thing coming in, there's nothing coming in here about the pharynx. It's coming in 9 and 10, so there wouldn't be any problem. Cornea. Now, cornea. If I had a lesion here and touched this cornea, you wouldn't get a direct or indirect. If I had a lesion here, touch the other side, you'd get both. So don't confuse it. E, S, E, F, G. Oh my gosh, this. Now look here. This is 8. This is 7, motor. This is the one that gives you the Bell's palsy. So anatomists have named this the intermediate between 8 and 7. Intermediate of 7. So how do you figure out what's in the intermediate branch of 7? Everything that's not motor. Taste would be in here. What ganglion? Geniculate. Pain and temperature would be in here. What ganglion? Geniculate. And then some fibers would be coming out here in the intermediate nerve from the superior salvatory lacrimal. So once you know all the branchiomotor fibers from motor 7 are in this branch, the bigger one, this intermediate nerve, you just think, what have I got left in 7? I know cranial nerve 7. I, auditory vestibular. Well, just think, you'd be deaf on this side, you'd stumble towards this side, you have a segment the opposite side. Where do these nerves end? Dorsal and ventral cochlear nuclei, if they're for hearing. Vestibular nuclei, if they're for balance. That's 8, 9, 10, 11, and let's please don't forget this one, 12, right here. All right? So let's do 12. Tongue go ipsy or contra? Tongue go ipsy. What canal? Hypoglossal. Let's do 11. Cell bodies are where? In the spinal cord. You'd lose your sternocleidomastoid on the ipsy side, so your chin would be a little bit contra. Your trapezius would be weak on this side. Let's see then, 10. Have a lesion here. Your uvula would be deviating to the opposite side. Lesion in 9 right here, you'd lose pain and temperature, taste from the posterior third of the tongue, and that poor little stylopharyngeus. So, know your cranial nerves. It'll be a challenging question. I'll ask you a challenging. It's not going to be IDs. No IDs on this. But anyone who understands the functional components, like what is in the intermediate nerve? Where are the cell bodies? Where's the cell body for this? If you put anything, if you can put it all together, pretty well, you'll be able to answer this question. But I think you'll like the question, but it might challenge you in the end. Okie dokie. Now, gotta love now you're gonna say, what? I never been up here. I never been up this. He never, ever, ever spent any time up here. He spent all of his time at that darn level 3, and then he got behind. Well, I don't know. There's not too much here. This one is very important. Cerebral peduncle. Every cotton picking, corticospinal, corticobulbar, corticopontine. So if I had a lesion here, right here, I'd have a contra hemiplegia with all the things that go with it, a contra going tongue, and a contra face that's weak below the eye. Here's a substantia nigra. All you got to do here is think Parkinson's, rigidity, can't move much, what else? Akinesia, rigidity, trying to think of the other one, stumbling, all those classic signs of Parkinson's. You won't miss that question. The rubber-duber, what do you know about the rubber-duber? Well, it's certainly surrounded by fibers, isn't it? These fibers are from this superior cerebellar peduncle, rostral to where it's decussated. So if I had a lesion in the superior cerebellar peduncle right here, I would say you'd have a contralateral deficit. If I had a lesion in the rubroduber right here, I'd have a contralateral deficit too in the rubrospinal tract. FAB4, you're not going to miss anything there, but make sure you know that the TTT at this level has both pain and temperature and 2-point. This little thing here, you don't have to know this, but some people call this the brachium of the inferior colliculus. In every little auditory structure, we just say subtle auditory deficit. E is the superior colliculus. Remember what I said was important about this? Well, there are some fibers that leave here and cross and go way down the spinal cord as the tectospinal tract, but pressure on this from the pineal will give you Parinaud syndrome, Parinaud. C is a great nucleus, ocular motor. Some of these, they run down, here they are right here. Don't forget these. They run down here. Some are somatomotor, some are visceral motor. Preganglionic, parasympathetic, they'd be coming from Edinger-Westphal. So this is the whole ocular motor complex. It's pretty big. Well, it's innervating a lot of muscles. Sitting right there. Here's your MLF. G is a rubroduber. Now, this cranial nerve 3 would run kind of, those axons kind of run down here. So let's say we had a lesion right here. The left cranial nerve 3 with both somatomotor and preganglionic paras would be damaged. So in the ipsi, the lid would be down, the globe would be rotated down and out, and the pupil would be pretty darn big. Here's your nigra. So this is a good level, and I just want to show you, it looks good here too. Now this right here, D, is called the around aqueduct. This is a cerebral aqueduct. Periaqueductal gray. And this is the area that in rats, they suck electrodes in here, stimulated the rat. And the rat was standing on a hot plate. And they found there were descending pathways from this periaqueductal gray that went down to the spinal cord and brainstem to inhibit incoming pain sensation. So this is the periaqueductal gray. It's called SPA, stimulation-produced analgesia. Man prefers to lie still. This is a hard one to see. What's the point here? What do we got in the lesion? We got the inferior cerebellar peduncle. We got the dorsal and ventral cochlear. We got the vestibular nuclei. Up here, we certainly got the abducens, and we got motor 7. Abducens here, motor 7 here. So think about everything. This lesion right here, if you're getting the vestibular and the cochlear in here, and then the inferior cerebellar peduncle, you're going to have incoordination, ipsi, deafness, ipsi, and if you're wiping this out, you're going to stumble this way and have the nystagmus the opposite way. You go up in here, you get the abducens. You can't move your eyes, ipsi, all right? Motor 7, you're going to get some motor 7. You're going to have a Bell's palsy on the ipsi side, and you might have some damage to the superior salvatory lacrimal nucleus. This one, think about. This is very interesting. This is called, the guy had percutaneous transluminal coronary angioplasty, and what happened is when they were doing it, he broke off a piece of something, blood or something, and it lodged in this whole area right here. You see the white? Now this is kind of screwed up looking, right? But here's the fourth ventricle up here. Here's one facial colliculus. Here's another right in here. So it really got this area right here, okay? And this is a true case. This is called the 1.5 syndrome. So let's say it got the area enclosed in the red circle, okay? So could he turn his ipsi laterally? Could he turn the ipsi laterally? No. Could he turn the ipsi, let's do this. Could he turn the contralateral eye medially? No. And then if it got this guy right here, could he turn the ipsi eye medially? So let's go through this again. All right, this one right here means he can't turn this eye that way. This one, damage to here, means he can't turn this eye that way. And damage to this right here means he can't turn this eye that way. So, kind of interesting. It's called 1.5. Interesting. I'm pretty sure you can figure it out. What's this one? Peduncle, 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 peduncle. Sure. Well, let's see. What do we got? Inferior cerebellar peduncle, Ipsian coordination. Inferior cerebellar peduncle, Ipsian coordination. Middle cerebellar peduncle, starting from pontine gray over here, Ipsian coordination. Inferior cerebellar peduncle started from the contra inferior olive, DSCT, and CCT. Still the middle. Now, leaving the cerebellum, superior cerebellar peduncle. Cell body would be the ipsilateral cerebellum. The deficit would be Ipsian coordination. Same thing, Ipsian coordination. Crossing right here, bilateral. And now it's on the other side. And if you've got some of these fibers around the ruber, it'd be contralateral in coordination. Now, this shows one of our levels here. Let's see, let's go down here. This one is from right here. And this is how it looks in the MRI. All right? So right there, see that right there? Would be the superior cerebellar peduncle. Well, you know all this stuff in here. There's the MLF. You know the FAB4. You know the cortical spinal bulbars and pontines and pontines. Nothing, hardly anything there. Superior cerebellar peduncle. And then this would be on the right side. So where would the cell bodies be? They'd be in the right cerebellum. Where are they going? They're going to the contralateral red nucleus and ventral anterior ventral lateral nuclei of the thalamus. What happens if you have a lesion? Ipsilateral in coordination. Remember, if you get this superior cerebellar peduncle before it crosses, it's an ipsilateral in coordination. Ipsi, ipsi, oh, now it crosses. So now these fibers are around the ruber and going through it, contra. John loves eye movements. Well, you're darn right I do. Let's go up here. Oh, let's go up here, yeah. Let's point out some stuff you should know. You should know the cortical spinal bulbars pontines. You should know the FAB4. You should know motor 7. Whether or not you know the superior olive and lateral meniscus, I don't care. You should know the PPRF. You should know the STT, and it's not in the FAB4. You should know the abducens nucleus, and you should know the rootlets of the lower motor neurons going out to the ipsilateral rectus, right there, A. B is pointing to the MLF. You should know its cell bodies are in the contra abducens, that its axons innervate, go up to the oculomotor on the same side to innervate medial rectus neurons. C is the trochlear nucleus. Underneath it is the MLF. This is a nucleus that has cell bodies that go up and over and innervate this superior oblique. Here is cranial nerve 3, and I'm pointing to the preganglionic paracells up here that go out with the nerve and go out through the superior orbital fissure, go to the ciliary ganglion synapse. Postganglionics arise from the ciliary ganglion and go to the sphincter. All right, so be able to, now, let's just take one of these here. Let's try D. D is the Edgeworth-Westphal, true. These are all true. It contains preganglionic, what if I said, that's wrong. It contains preganglionic parasympathetic cell bodies that travel with the somatomotor fibers, that's true, and synapse on cells, that's all true except for that darn thing. This nucleus lies in the pons. What's this? Midbrain. And a lesion results in a dilated, yeah, boy, I mixed it up. I really mixed it up for D. Let's try C. Let me see if I was just as good on C. C is the trochlear. Now, don't anybody try to tell me that I'm pointing to the MLF there, all right? C is the trochlear nucleus, that's right. It is comprised of lower motor neurons that innervate the contra, yes. A lesion of this nucleus results in double vision, darn right. And to alleviate it, one would tilt their heads to the ipsi side to the nucleus. So remember, You go over here, here's the muscle, and you tilt opposite the weak muscle, which would be ipsy to the nucleus. Very good. And flex their chin, that's true. Cranial nerve 4 is the only cranial nerve to exit from the dorsal aspect of the brainstem. Is that true? And is it caudal midbrain? Yeah. I love this. I love this. I did this one. Didn't I? Didn't I give you this? I did this. Why do I have this in here again? Okay, let's see. Ah, the uvula. Oh, this is unreal. I found this on the internet. This is unbelievable. Look at these. These are the palatal arches and the uvula. You know, so I'm thinking tongue, pharyngeal, glossopharyngeal. And this is all cranial nerve 10. All of this. Now look, if I cut it right here, I have everything that's in cranial nerve number 9. Right here. And then they go different places and come in from different places. So here's a ganglion A that is part of 9 that goes into the spinal tract of nucleus 5. What's the ganglion? Superior or inferior? Superior, pain and temperature. Here's another ganglion. Comes in, goes to the rostral part of solitarius. Taste. Anterior, posterior third of the tongue. Which ganglion? Well, this is superior. Taste is inferior. Ooh, then I got another one. Ooh, coming into the caudal visceral part. Probably involved in the carotid sinus reflex or something like that. Ganglion, inferior. Now I got 2 going out. 2 going out, one from good old nucleus ambiguous. Oops, going like that. Stylopharyngeus, one poor little muscle. And then I've got the preganglionic para with 9 coming from the inferior salivatory, going out to the otic. Wow. That's all cranial nerve 9 here. Cut it here, you don't get anything associated with all these. Why did I come up? Why do I keep doing this? Oh, the wanderer. The wanderer here. I like this one here. I am a wandering along the... Anyway, cut it right here. Cut it right here. You don't have it. Look here. All this is 10. All this is 10. Some people haven't figured that out, and it's my fault. This is all cranial nerve 10. Again, you got a ganglion that goes in the spinal tract, superior, pain and temperature. You got another ganglion that comes into rostral solitarius, inferior, taste, epiglottis. And you got another ganglion that comes in caudal solitarius, inferior ganglion, aortic bodies, carotid sinus, that kind of stuff, okay? And again, you got 2 going out. Now, like 9, there's something coming out of ambiguous, but it goes to a heck of a lot of places. And we'll give you your uvula problem. And dysphonia and dysphagia and all those goodies. And in contrast to 9, whose preganglionic para came out of the nucleus here, here's your preganglionic para here, dorsal motor 10. So it looks a lot like 9, except covers different parts, does different things, and when I look at them, this one's got its preganglionic para and dorsal motor 10. 9 would have it inferior salivatory. Well, this one, I'm not even going to, geez. Make sure you know what these all are and do, please. Well, when I look at this one right here, I think about the formation of the medial lemniscus. So I've got big, huge dorsal column nuclei. Big, huge dorsal column. Fasciculus gracilis, nucleus gracilis. Fasciculus cuneatus, nucleus cuneatus. Spinal tract 5, spinal nucleus 5. Dorsal spinal cerebellar tract. ALS descending hypos. These are called internal arcuates because they're coming down like that and crossing right in here. Coming down like that and crossing. So lesions in here would give you ipsy problems, 2-point, etc. And also, don't forget, in cuneatus, you got at this level, out here in the DSCT, you got C8 and below. C7 to C2 up here for unconscious proprio. But remember, these will give you ipsy problems coming down like this, get these internal arcuate fibers. If I ask you where their cell bodies are, you'd say ipsy nucleus crassus, ipsy nucleus cuneatus. Where are they going to terminate? Contra VPL via the medial lemniscus. Cut them, going to be an ipsilateral loss at 2 point. G, pain and temperature loss, contraside of the body with ipsy Horners. I, loss of pain and temperature from the ipsy side of the face. Come over here. Wow. Well, I always told you, I hope you never forget, if you got a fiber in the pyramid, you're going to have a contralateral Babinski, etc. Contralateral, right here, contra. Now, these have already crossed, so these are the beginning of the LCST, so you got to think, oops, that's not it. The pyramid's down here. The pyramid is something you can see. You can't see these. So if I say, this is a pyramid, always guess contra. Well, this, you're going to say, gee, they're going like that. So now we're going to have an ipsilateral problem. ALS, you know that. I might ask you where these cells send their axons. You could say cross, go up to TTT, all the way to VPM. You could also say cross and go up to nucleus ambiguous on both sides. Ooh, cross, go up to TTT. Some get off to this nucleus ambiguous and this nucleus ambiguous. Some just keep going up to VPM. This right here would be fasciculus cuneatus. It's got 2 point in there, but remember, it's also got some C2 to C7 unconscious proprio. I don't think you'll miss this question. I think that, now, you see here on pages 378, you're going to have every level of the brainstem. See? Oh, where's my, oh yeah, what did I do here? Well, medulla levels 1 to 4. Here's medulla levels 1 to 4. Pons here, right? And these are midbrain. So I'm going to either put this up, these 2, these 4, or these 4. And then I'm going to give you a list of symptoms that you could get if you had a unilateral lesion. Now, when I say a unilateral lesion, I say one side. Could you get the deficit if you just got it? In other words, if I was talking about, say I was talking about this level, and I said the left side is gone. Could you get a particular deficit? Don't combine deficits. Just say, could I get the deficit with a lesion of this pyramid? Could I get the deficit with a lesion of the LCST of these things, okay? So I think I got one to practice on. So you know you won't see this one. So let's try this, see. I'm trying to think whether or not these are on the, I tell you it's on, the lesion's on the left or right. Let's say, I bet, let's see, gag reflex, right Babinski. Let's say, let's try, I'm trying to figure out whether the lesion's on the right or left. Atrophy of left lateral. Deficit, well, okay, let's go through the atrophy of left. I'll bet it's left. Let's try left. I wiped out the whole left side here. Everything in it and everything in this one. So I just drew a line. Everything is gone. And I take each structure individually. So let's do loss of the gag reflex. So are there any structures in here, that would cause you to have any problems with your gag reflex? I'd say no. I don't see any. Are there any structures in here that would give you atrophy of the left inferior rectus muscle? Yes. Ocular motor nucleus. Oh, my hand is shaking. Left ocular motor nucleus would give me atrophy of the left inferior rectus. Is there any structure on the left side would give me atrophy of muscles on the left side of the tongue? No. You don't get any atrophy from cortical bulbars. Is there anything in here give me atrophy of the left lateral rectus? No. The only you've got the trochlear nucleus here for superior oblique, and you've got the ocular motor here, but nothing for lateral rectus. Sure, you got the MLF, but that's not going to give you anyone. Deficits associated with Parkinson's. Is there anything here or here? Yeah, substantia nigra. Ooh. How about loss of taste from the left side of the tongue? Anything on the left side here? Yep, STT, STT. Right Babinski. Well, cortical spinal, bulbar pontine on the left side would give you a right Babinski. That's true. Weakness of facial muscles below the eye on the right. Yep, yep. Cortical bulbars here on the left. You've got the cortical spinals, cortical bulbars here on the left. You'd have a right hemiplegia, a right going tongue, a face that's weak on the right below the eyes, uvula standing tall, and a jaw standing tall. Left internuclear ophthalmoplegia, inability to turn the left eye medial upon looking to the right. Well, it's just a big name. Let's see. Oh, how about right here? Right there. Now remember, the lesion only involves the left MLF. You don't have a lesion of the left ocular motor. You've got to take each one individually. So if you had a lesion of the left MLF here, could you have the inability to turn the left eye medially? Yeah, and we call it internuclear ophthalmoplegia. Could you have any subtle auditory deficits? Well, if I was going to guess on subtle, I'd guess yes. That's picky. But here's a lateral lemniscus here. Or brachium of the inferior colliculus. See, I even forgot. But this thing right here, you see this thing right here? This is the inferior colliculus. This is one of the biggest auditory structures in the world. Inferior colliculus, auditory. Inferior colliculus, auditory. Subtle. And then there's some lateral, some lateral lemniscus and stuff in here. So I'd say, darn right you'd have subtle auditory deficits. You know what? I'd guess that on about any side of the brainstem from level 4 up, because those pathways are ascending. I think this is the last slide. I don't know. Let's see. That's it. Well, let me tell you, it's been great. I expect everybody to get 100, and I'm pulling for everybody to get 100. If you don't, hey, come on. That's okay. Try to learn as much neuro as you can, but you can't learn everything. And if you don't get 100, I'll still love you. So have a good evening. Bye-bye.